Hello and welcome to Med Talks with Dr. Moin. This is a beautiful month of the year, March. Not because of the season, but because of a reason we have. So every month of March is being celebrated as Women's Month. So can we talk about women who are mostly ignored? Many a times we do so many things, but we ignore our women. Women are very special, we know that at the same time. So to talk about women's health and women's heart, let's welcome Dr. Deepthi, who is an interventional cardiologist at Care Hospitals, Nampalli. Hello, ma'am. Welcome to our studio.
Thank you first for inviting me.
We never associate heart disease with women, but it's very common disease nowadays.
Women in heart disease is often underestimated, and
Okay.
the exact gravity of the situation is not known by most of the educated population also. Actually, in a study in abroad, Harvard Medical School conducted in educated middle-aged women a questionnaire.
Okay.
All of them opted as their first prior leading cause of death. All 87% opined as breast carcinoma.
Okay.
Only 13% knew the correct leading cause of death in women is heart disease.
Okay.
That shows how we are lacking, how the community is lacking in the general awareness.
Okay.
As for any disease, particularly of this severity, severe consequences, the first thing is health education and
Right.
understanding the disease, then we can take the appropriate diagnosis treatment. So
Okay.
this is in the West. Imagine in India, it's still very few people, educated people also, somehow a wrong notion of I'm women, I may not get heart disease, like that is there. Actually, whereas the truth is, no age or no sex is immune to heart disease.
Right.
The human itself, you are prone
Right.
to heart disease, and the risk varies depending on your age and your other comorbid issues before menopause, after menopause. Those things have to be addressed. So this is a nice platform where we can just, I just want to tell that in women, heart disease is the leading cause of death.
Okay.
And it can be majority of the cases are preventable by proper screening methods and strict adherence to the treatment.
Okay. When we say women's heart, is women's heart anatomically different from men's heart?
Anatomically, heart is not different in both the sexes. Men's heart and women's heart is the same.
Okay.
But the general body metabolism and the structure and other issues put certain and the other organ functioning and the hormone impact.
Okay.
That effect on the heart is slightly different. Premenopausal women, female hormones are very protective
Okay.
against the development of atherosclerosis and the coronary artery disease.
Okay.
Simply telling the deposition of this cholesterol in the blood vessels and causing heart attacks, that chance is much lower pre-menopause.
Okay.
But after menopause, actually this difference is nullified, and in fact post-menopausal women are at more high risk.
Okay.
And but this does not apply to every woman.
Okay.
Even premenopausal women are more susceptible to heart disease if they have other risk factors.
Okay.
So it's not the anatomical difference in the heart, but it is the effect of the female hormones and their other concomitant comorbid conditions, and the differences in the risk factor profile in these two.
Okay.
Like few of the addictions which were earlier more seen in men, but now no longer, even some of the
We are even seeing in females. Yeah.
So those factors, if they are added upon,
Okay.
in fact females have a more higher risk of developing compared to a male smoker. Female smoker has 3 to 4 fold increased risk in developing heart disease.
Oh my God.
So these issues have to be considered. That is why it's not that they cannot get, but
Okay.
yes, in the reproductive years and when normal functioning hormone levels are there, premenopausally women they have a slightly lower chance
They are like-
compared to men. They are protected.
Okay. All these addictions, habits, smoking, alcohol, what kind of impact do they have on a woman's heart?
Common risk factors are similar in both the groups, like
Right.
diabetes, hypertension, and smoking, cholesterol abnormalities.
Yeah.
But the issue is the same diabetes in men and diabetes in women. Diabetic women are again more prone to develop much multifold more risk of developing heart disease.
Okay.
And some modifiable risk factors like sedentary lifestyle.
Right.
And now it's called sitting is the new smoking.
Right.
Sitting and prolonged sitting and doing work.
Oh, you call it a new type of smoking?
Sitting is called the new smoking.
Okay.
It is equally and often underestimated risk for developing the heart disease. Sedentary lifestyle and excessive stress levels. Whatever. God has made some differences.
Right.
So their ability to cope up to stress and respond to stress, the stress is an often, though the risk factors are similar in both the group,
Okay.
but excessive, we see heart attacks and all precipitated more by emotional stress in women.
Okay.
And other specific diseases which are unique to women, like earlier you have discussed the polycystic ovarian
Right.
syndrome, which is as a part of insulin resistance in the body. So those people are more prone to develop heart disease.
Okay.
And extra other diseases like connective tissue diseases, lupus. In
Okay.
fact, in my practice, 14 years boy with lupus was the first came with an inferior posterior MI.
Oh my
Over
God.
Care Hospital.
14-year-old
years
boy.
He was in his ninth standard.
Oh my God.
He's now doing well. So some connective tissue diseases, these are more common in women.
Okay.
Particularly lupus, rheumatoid arthritis.
Rheumatoid arthritis, yeah.
And along with these issues which are specific to women, the pregnancy-induced hypertension, eclampsia,
Yeah.
and gestational diabetes. These are often because even many years after pregnancy, even they tend to forget, they do not get their screening done, but their body has that metabolic impairment. So that affects the natural blood vessel lining of even the coronary arteries, so they are more prone. So these are some risk factors which are unique to women, the PCOS, the eclampsia, preeclampsia, gestational diabetes, and susceptibility, vulnerability to emotional stress.
Okay, ma'am.
So this applies to any age of the women.
Okay.
Coming to the normal menstrual cycle and premenopausal and postmenopausal, there is a sudden surge in the incidence of CAD before menopause and after menopause,
Okay.
because the protective levels of this female hormones is lost suddenly.
Unlike men, women have some different phases of life. They have some premenopausal condition and postmenopausal conditions. Apart from these conditions, is there anything like a women's health needs more attention than men's health? Like the comorbidities are, and are they different, ma'am, from when compared to men?
Menopausal women have a very multifold higher risk of developing CAD. At the same time, by that age, they have this other comorbidities like diabetes, obesity, and hypertension.
Okay.
So all this multiply their effect. In any disease which is affected by multiple risk factors, the cumulative effect of all these risk factors increases the risk multifold.
Okay.
And so this has to be taken care of.
Okay.
And we have to do, the only remedy to this is just understanding that I am a women, the possibility of I having heart disease is low is a misconception.
Okay.
Yes, which is to a large extent decreased now, which was few years earlier. And I am younger age, I will not have, no age is immune.
Okay.
In fact, what we experience, the commonest cause of heart disease, the atherosclerosis, begins in the first decade, 6
Right.
to 7 years of age. Below 10 years, the fatty streak, the deposition of cholesterol in the blood vessels, occurs in the first decade of life.
Okay.
So even, which I quoted the example of 14 years boy presenting
Right.
with a heart attack. So it is no age is immune to developing. Just following the community guidelines, above 30 years, just getting a simple lipid screen or a glucose level, HbA1c.
Madam, do you have a set of investigations for women who are in their early 30s or early 40s, or maybe who have crossed their postmenopausal phase?
Yeah, no specific. The American Heart Association, in conjunction with ADA, they have formulated a guidelines in that no specific sex differences, but it is like similar to male.
Okay.
HbA1c level, periodic screening of the blood pressure,
Okay.
and the basic fasting lipid panel. These are mandatory.
Okay.
Along with that, a CT coronary angiogram, even though not a detailed one, just an electron beam CT.
At what age you want this
Yeah,
to be
actually
done?
we baseline, whenever whenever a patient presents to us without an established, these all screening won't apply if the presentation of the patient is a direct angina, stable angina or an unstable angina or an ACS or an MI. It applies to a person who is not had a heart disease yet, but who is having the risk factors. Then based on the classical Framingham risk score, which has been modified, we assess their 10-year risk of developing a CAD. And we classify it as low, intermediate and high. Those with intermediate, those with high risk, we directly prefer a CT coronary angiogram. And in fact, if they have some vague symptoms, individual physician can decide upon a direct coronary also. But a CT is the best screening in those with high risk. In those with intermediate risk, what we do is we just subject them to a stress test. Like in addition to the basic biochemical panel which I have mentioned earlier, like HbA1c, lipid panel and monitoring their blood pressure, BMI is a simple, cheap tool which also helps us to assess. And there are other tools which are, anybody will know, the ankle brachial index, just auscultating for a simple bruit. These are the cheapest, no cost, only just basic awareness and consulting a physician. No need to consult a specialist, cardiologist also. So the ankle brachial index, auscultating for some carotid bruit and peripheral pulses are fine, monitoring their blood pressure. In addition to these, in intermediate risk group, we ask them to go for a stress evaluation. Treadmill test is the simple, cheap, available everywhere, even in remote rural areas. And because the moment we refer to screening, two things are prerequisite: the sensitivity of the test and the cost of the test and the access of the individuals to that test. CT is not accessible in remote areas, whereas treadmill test, even in villages or at least in a district level, you will get. And treadmill, the greatest advantage is not only to identify the presence of heart ischemia, in other words, is there any blood supply deficiency to the heart when he is exercising. In addition to that, we will know the work capacity of the patient.
Of the heart, right? Whether, how the heart is behaving when the
work efficiency, how much is he able to exercise. And that is a very important thing, because depending on that, you counsel, you can set a rehab program for him later. Even now that may be negative, but in future to adjust his lifestyle, to prescribe a regimen to him, it will be very useful.
Thank you so much for spending your valuable time with us. And this information is going to be useful and is going to save so many lives, especially the women's life, very special.
Thank you.
Thank you, madam.
Thank you so much for watching us. Please stay tuned to Mozomin. We'll continue talking to Dr. Deepti about women's health in coming episodes. Thank you.
Welcome to Med Talks with Dr. Moin.